nephrology review. So question 1, 82-year-old female, type 2 diabetes, hypertension, hyperlipidemia, and CKD. Her creatinine is 2.3 milligrams per deciliter. She has chest pain consistent with ischemia, a positive stress test. She's given IV fluids and N-acetylcysteine, and she gets stented and started on clopidogrel. About 4 days later, she develops oliguria, azotemia. Her creatinine is up to 2.8. She has abdominal pain and some GI bleeding, which is the most likely cause of her AKI. Cholesterol embolization, let me just start the questions. Cholesterol embolizations, prerenal azotemia, ischemic ATN caused by hypotension or contrast nephropathy. All right, I'll give you about 10 more seconds. Okay. There we go. Okay. So we have about 30 answers. Most of you felt that she had cholesterol embolization, with some of you thinking it's contrast nephropathy. Okay, so, sorry. So the right answer is that this is cholesterol embolization. The reasons for that are that the acute kidney injury occurred about 4 days after the catheterization. Contrast nephropathy, at least classically, should occur within 1 to 2 days. You should see a rise in the creatinine and oliguria if you're going to see any. Abdominal pain, fever, GI bleeding are all suggestive of embolization. You can occasionally see peripheral eosinophilia or depressed complement levels, blue toes, of course, and an active sediment. That is because this is not just an ischemic injury, but the cholesterol embolization seems to set off an inflammatory cascade, and one can diagnose it on renal biopsy. I don't know that renal biopsy is incredibly sensitive for it, but you can find cholesterol clefts in some cases which are diagnostic of cholesterol embolization. Case 2. I'll put let you just start answering. A 25-year-old female, a 25-year-old female with no significant history is referred by her primary care for hypertension. She's thin, has a pretty normal exam, has no edema. Her blood pressure is quite elevated, but equal in both arms. Urinalysis is normal. Labs notable for a creatinine of 1.2 and a potassium of 4. Bicarb of 24. She denies any off-prescription medications and doesn't have a family history that's notable. What's the next step in the workup of her hypertension? No additional testing, 24-hour collection for catecholamines. I believe you just heard about that in the last talk. Renal artery imaging or genetics testing for Gordon's. Oh. Okay, so most of you want to do renal artery imaging, and I think that's the correct answer. Okay, renal artery MRA is done. It's the following results down here. What's the most appropriate next step? Renal artery bypass, renal artery stenting, angioplasty, or ACE inhibitors. Okay. All right, so this one we had a little more debate. Exactly the same number of people want to stent or do angioplasty. And I think the right answer is angioplasty without stenting. We'll get to that in a second. So this is most likely secondary hypertension given her young age and relatively abrupt Gordon syndrome is an interesting disease caused by an activating mutation in the thiazide channel due to abnormalities in Wnt kinases, but it's unlikely to have an onset at this age. It should present earlier and not suggested by the absence of a family history of hyperkalemia. Renal artery stenosis, in contrast, is the most common cause of secondary hypertension. May be present in 40% or more of patients who present with malignant hypertension. In a young female like this, the most common cause would be fibromuscular dysplasia, as opposed to the more typical population that we see where they tend to have atherosclerotic renal artery stenosis. The typical imaging appearance of fibromuscular dysplasia would be a string of beads. And as opposed to atherosclerotic disease, this entity tends to respond quite well to native angioplasty without stenting. And putting a stent in does increase the risk of thrombosis and need for anticoagulants, so best not to in this case. Fibromuscular dysplasia can be a systemic disease, so you'll want to also consider imaging in other vascular beds, in particular the carotid arteries, because it can occasionally cause strokes and cerebral ischemia. Question 4. I'm going to just let you start answering. I'm going to move this up here. Okay. A 43-year-old male construction worker presents after being found at home confused. He's last seen in good health about a half a day earlier. He's afebrile, a lowish blood pressure, and some tachycardia. He is arousable, but he's definitely lethargic and confused, shallow respirations, clear lungs, benign abdomen, non-focal exam. His labs are notable for a normal white count, a sodium of 141, potassium 4.2, the chlorides 102, bicarbonate 12. There's some moderate elevation in BUN and creatinine. His glucose is normal. The lab UA has a pH of 5.5 with negative ketones, trace proteins, rare reds and whites. Head imaging is normal. So what's the best combination of tests? Lumbar puncture, blood and urine, blood gas and toxicology, blood gas, lactate and serum osm, or methanol and ethanol levels. I don't seem to be getting any answers, or am I just missing? There we go. Sorry about that. Okay. Okay, so most of you want to get blood gas and lactate and serum osmolality. I think that's the right answer. An hour later, the patient's wife is reached. She states he's been depressed, and she found an empty bottle of antifreeze in the kitchen. What's the next step? Ethanol, CVVH, dialysis, or dialysis with fomepizole? Okay, most of you want dialysis and fomepizole. That's correct. So, let's review. The dominant features are his mental status changes, an anion gap acidosis, and no infection. These findings, I want to emphasize, should always raise a red flag about the possibility of ingestion. Most of the time they won't be, but I've personally seen a patient who got the $1 million workup in the ED for an anion gap and some confusion, and he got an LP, he got a head CT, he got an MRI. Only at some point later did they say, gee, could this be an ingestion, and get us involved. And at that point, it may have been too late even at the beginning, but it was clearly too late to help the patient at that point. So think about this when you can't explain the anion gap quickly. A blood gas is, just as a reminder, needed to confirm the presence of acidosis and make sure that this isn't a respiratory alkalosis with compensation. Lactate level will help you to rule out lactic acidosis, although I'll caution you that if a patient is at the stage of having cardiovascular collapse, they may have lactic acidosis in addition to an ingestion-based acidosis. The reason to measure osmolality is that it allows rapid calculation of the osmolar gap you'll see various levels in the literature, but a gap of greater than 20 is clearly suggestive of an ingestion, whereas a gap of 10 to 20 is something we see more commonly from other causes. However, of all these causes, ethanol, ethylene glycol, isopropyl, only methanol and ethylene glycol are likely to cause this degree of acidosis, whereas isopropyl alcohol ingestion should not. Methanol levels and ethylene glycol levels, if you can get them rapidly, that's probably the best test. But in most hospitals, those are send-out tests, so they're not going to help you diagnose the ingestion very quickly and in the time frame you need to take action. Turnaround time is probably too low in most places to use these as anything other than confirmatory tests after the fact. When the suspicion is at least moderate, you can start dialysis and famotidine on the basis of the osmolar gap alone, particularly if there's an unexplained anion gap, and then hope that when you get the levels back a day or two later, you're going to confirm an elevation. The acids involved for ethylene glycol gets converted to glycolic acid, methanol to formic acid. Be aware that the osm gap is produced by the parent compound, not by the acid. So what that means is that the acidosis with an anion gap and the osmolar gap may not be concurrent. That the osmolar gap may go away as the ethylene glycol, for example, is converted into glycolic acid. Your osm gap goes down while the anion gap goes up. CVVH will remove toxic alcohols, but the name of the game here is to get rid of them quickly. But they have a large volume of distribution. So what you want to do is prolonged hemodialysis therapy. There are some papers out there that allow you to actually calculate based on the level how long a therapy you need, but this would typically be 6 or 8 hours of dialysis for rapid reduction level and then come back the next day. Personally, that's kind of hard to do, although justifiable. So what I often do is a somewhat shorter of a 5 to 6 hour dialysis, and instead of coming back the next day, you can put the patient on CVVH if that's available to you. That'll continue to reduce the levels as they re-equilibrate out of that large volume of distribution so that it never rises again. By the next morning, you should be done. Indications for dialysis and famotidine use are at least moderate acidosis, pH less than 7.3, the presence of renal failure, which means you're not going to metabolize and excrete those compounds, or a level greater than 50 for the toxic alcohol. And if you know the molecular weight, you can back calculate the approximate level of the toxic alcohol on the basis of the osmolar gap. Question 6, 68-year-old female with dialysis, secondary diabetes, and hypertension. She's on hemo. Her medications include aspirin, atorvastatin, insulin, and lisinopril, which they hold pre-dialysis. You can see a few others listed. She generally has rails pre-dialysis and peripheral edema with an elevated blood pressure. Her intradialytic weight gains are not too bad at 2.5 kilos. She has a dry weight of 72. The attending nephrologist asked nurses to change it to 70 kilos in an attempt to remove edema and achieve dry lungs. But over several weeks, she has repeated cramping and intradialytic hypotension. She can't get there. She receives 4 hours with sodium modeling. It's pretty standard blood flow and dialysate flows. What should you do next? Change her weight back to 72 kilos, give albumin during dialysis, change the dialysis orders to isolated UF, followed by dialysis, or cool the dialysate. Okay, most of you want to cool the dialysate. Good. I would say actually the first answer is really what you need to do is review the flow sheets, because if your dialysis unit is anything like mine, there's a variety of nurses, and a lot of times they say that that you need to change. I get a call from one of my nurses like every 2 weeks saying I need to raise the dry weight because a patient cramped. And the answer is no, you don't. He came in 6 kilos over his dry weight. They were trying to get all that off in one treatment. There's nothing wrong with his dry weight. They just tried to go for too much in that particular day. So you really need to look at the flow sheets, understand what's happening if you can. That said, intradialytic hypotension is common. Occurs in 20 to 30% of treatments. It's a repeated issue in a smaller percentage of patients. When it's frequent, it's associated with a high risk of morbidity and mortality. Whether that's causal or just marks vulnerable patients remains unclear. The etiology is complex, but is related first and foremost to the volume of ultrafiltration relative to the ability to re-equilibrate that fluid from the interstitial spaces into the vascular tree and fill the vascular tree as we take fluid off. But in addition, there's impaired catecholamine release, so our compensatory responses and hormonally are impaired. There's automatic neuropathy and impaired vascular tone in a lot of our patients. Increased adenosine levels have been found in dialysis patients, and adenosine is a vasodilator. Our patients have reduced myocardial contractility and stunning, as I mentioned in the prior talk during dialysis, and that may impair the ability to increase contractility as blood pressure goes down. So all those factors combine for quite a lot of hypotension. Available treatments are listed: cooling the dialysate, sodium modeling, ultrafiltration profiling, and so forth. A couple of interesting ones. There are studies looking at using just a simple maneuver of either an abdominal band with the idea being if you squeeze down the belly, you'll return blood flow up into the chest. Or more simply, you can just put the legs up on a pillow. Patients don't really like the abdominal band, although it did work in a clinical trial. Adenosine antagonists have been tested outside of the US. Coffee, by the way, is an adenosine antagonist, so you can consider that asking your patients to just get some Starbucks before dialysis, although there's some fluid load with that. Midodrine and vasopressin have also been tested in clinical trials. So clinical trials have been done. These are generally done on patients with either repeated intradialytic hypotension, not so much in the ICU setting where this is also quite a bit of a problem. But clinical trials support cooling the dialysate, sodium modeling, the use of the abdominal band, adenosine antagonists, midodrine, and vasopressin have all been studied and proven in usually crossover trials to be effective. In contrast, isolated ultrafiltration and albumin infusion don't appear to be all that effective, although one again should consider the patient population. These were mostly outpatients. They may be effective maneuvers if you're talking about ICU nephrology with patients who are profoundly hypoalbuminemic, but certainly not as well proven as these other therapies. Cooling the dialysate is well tolerated, especially if you get there slowly. So if you start a patient out at 36.5 and they get used to it and then mark them or walk them down to 35 or so, generally you want to go about a degree or so cooler than the body temperature. That prevents heat transfer from the dialysate to the patient and then vasodilation in response to the heat. It may actually improve myocardial perfusion and contractility and reduce stunning. It's free. So this is my go-to modality, I think the best proven, potentially with some long-term benefits. And in fact, there was a recent clinical trial. It didn't meet its primary echocardiographic or MRI endpoint, but most of the secondary endpoints suggested that there was improved cardiac function in patients who were randomized to cooling the dialysate versus a standard dialysate. So if your patient tolerates it, I don't personally see any reason not to use this modality. You do have to stay on top of the nurses and remind them to actually follow that order. And if you're like in a Fresenius unit where they get rewritten every few months, you got to go back in there and put the order back in and then make sure the techs actually follow it. Of all these modalities, it's the only one where there's at least a suggestion of not just an effect on hypotension, but potentially long-term benefits, although not proven, just sort of suggestive. Sodium modeling works, but the problem is that if you start with a higher sodium, patients may leave a little bit hypernatremic or relatively hypernatremic, then they go home and they drink more. So while on an individual treatment basis it seems to work to reduce intradialytic hypotension, it may overall set you back if you look at the patient over the course of weeks. Question 7. 77-year-old with a few days of nausea, vomiting, constipation. He has a history, he's confused and lethargic. He has a history notable for Crohn's disease, hypertension, heart failure, some cardiac disease, and a baseline creatinine of 1.6. He's hypotensive and bradycardic. He has a tender belly with some distension and absent bowel sounds. His exam is also notable for the absence of deep tendon reflexes and dilated pupils. Which of these likely explains his presentation? Hypokalemia, hyperkalemia, hypercalcemia, or hypermagnesemia? Okay. Okay, so people had some trouble with this one. This was a hard one. Split between hypokalemia and hypermagnesemia as the most common answers. So the correct answer is hypermagnesemia. This is actually based on an actual case. Over several hours, his blood pressure comes down, the bradycardia gets worse, he begins to require pressors and becomes oliguric. Ultimately, he's intubated, and he has imaging showing an ileus and some pulmonary congestion. His labs now show most notably acute kidney injury and a very profound hypermagnesemia. Treatment should include dialysis, calcium infusion followed by dialysis, saline and Lasix, or CVVH. Okay. All right. Again, people are a little bit split. Most of you just want to dialyze them. So actually, I think the answer B is the correct choice. Dialysis should be part of the picture, but it's not the only thing that one should do. Oops. The patient has hypermagnesemia, of course. Symptoms of magnesium intoxication include GI symptoms with nausea, vomiting, and ileus, neurologic symptoms with depressed reflexes and autonomic dysfunction, so decreased parasympathetic tone with dilated pupils, ultimately respiratory symptoms with respiratory depression, and then cardiovascular manifestations with bradycardia, eventually prolongation of your intervals, and eventually hypotension and cardiac arrest. Most filtered magnesium is absorbed, is reabsorbed. There's a huge capacity for normal kidneys to excrete magnesium and regulate it. The regulation is fairly similar to the regulation of calcium excretion. But you can become hypermagnesemic when intoxication is combined with some degree of impaired renal function. Generally, these are somewhat arbitrary, but mild toxicity is a level that's above normal but less than 6. It's considered moderate in the range of 6 to 10 and severe when it's 10 or higher. So in the absence of the concurrent symptoms, this patient would have been considered to have moderate toxicity, but obviously he had pretty profound symptoms. For reasons that are unclear, except perhaps that the substrate tends to be pretty good with IV intoxication, toxicity seems to be much more common with oral, which is presumably chronic intoxication. The IV use of magnesium is mostly in the setting of preeclampsia given to OB patients who otherwise are pretty healthy, and maybe that's why they can tolerate fairly significant elevations in magnesium without having major symptoms. Severe symptoms have been described with levels in the range of this patient, 6 to 10, and it wouldn't be unusual, so you obviously have to use symptoms and not just the absolute level to decide what to do. With mild toxicity, you can use fluid and diuretics as long as renal function is preserved. But with severe toxicity, you want to consider dialysis. As with almost all intoxications, if someone is experiencing toxicity from a medication or endogenous electrolyte that is dialyzable, you want to remove it quickly before catastrophe happens. And so dialysis is almost always the best initial modality, even if you want to follow that up with CVVH as opposed to a second treatment of intermittent dialysis. Dialysis is obviously indicated when you have manifestations of toxicity or a very high level, and a CVH is just too slow, but obviously could be useful if the level is very high and you want to bring it down, continue to bring it down after your initial dialysis. The idea of giving calcium is that magnesium and calcium attach to the same receptors, and you can essentially displace or protect those receptors by administering the calcium and prevent some toxicity. Okay, about 10 minutes left, and I think 4 or 5 questions. A 72-year-old dialysis patient presents with chills, positive blood cultures for staph. He dialyzes via a right IJ tunneled line, has defunct fistulas on both arms, as well as stenosis of the jugular and veins on the other side and subclavian veins. His temperature is 38 degrees, his heart rate 100, BP is normal. He looks uncomfortable but not toxic. What is the next best step? Immediate line removal and vancomycin for 3 weeks, vanco without line removal, vanco and exchange of the line over a wire, or a gentamicin lock. Okay. All right, so most of you want to exchange over a wire. A few of you want to just take that catheter out. So this is debatable, but I think wire exchange is probably the best choice. Over 48 hours, the patient develops a pressure requirement. He continues to spike high-grade temps. What do you do now? Get an echocardiogram, rule out endocarditis, pull the catheter, use temporary catheters until he's stable, add gram-negative and fungal coverage, or go to a citrate lock. All right, at this point, most of you want to pull the catheter out. And that is, I think, the correct thing to do. So to review, this is a patient initially with a line infection who's clinically stable, and certainly an extended antibiotic course for a deep-seated infection is appropriate. Most people would recommend at least 3 weeks of antibiotics, but there are people who treat shorter than that. I think there's probably a little downside to the longer treatment. We used to treat through lines in a lot of patients and got away with it most of the time in our dialysis patients, but actually if you look systematically, there's actually a pretty high rate of recurrence and really potentially catastrophic complications like endocarditis, spinal infection, and osteo. So that's not recommended for the vast majority of cases. You can take the catheter out and just treat with temporary lines for a few days. It's not wrong, but the problem is that not only does the patient need multiple procedures, but this is a patient who's had multiple catheters, has stenosis in multiple veins, has burned through a bunch of access sites, and you'd really like to preserve his access if possible, if you can do it safely. And guide wire exchange in stable patients accomplishes that. While it hasn't been proven in randomized controlled trials, there are pretty convincing case series and before-after studies. It avoids the need for a temporary line, and there are very high rates of cure without recurrence, comparable to what you would get with just removal. Gentamicin and antibiotic locks are highly effective for gram-negative infections. They're difficult to get in outpatient dialysis units, so you need to know what your local practice and availability is, but they are less effective for gram-positive infections like this one, probably because of the nature of the antibiotic used. Okay, 35-year-old man with acute flank pain and a non-obstructing calculus on imaging in the right UPJ, some smaller stones as well. He's sent home from the ER with narcotics and told to follow up with his nephrologist. In addition to analgesia, what should you do at this point? Refer to urology for lithotripsy, a 24-hour collection, and a metabolic workup, straining the urine and analyzing any stones that you find, or D, no workup necessary because of the first stone, or B and C. All right, most of you chose answer E. You are correct. Medical history is remarkable for hypertension, no family history of stones, and an unremarkable dietary history. He takes atenolol. Urinalysis and serum chemistry is unremarkable, and his PTH is normal. His 24-hour urine shows the following: 1.7 liters of volume, 400 milligrams of calcium excretion per day. Oxalate is 45, citrate 150, urate 145, and the sodium is 190. His pH is 6. What should you recommend? Increases urine volume, start allopurinol, potassium citrate, increases fluid intake, and decreases salt intake, or substitute hydrochlorothiazide for his atenolol. Okay. All right. Most of you want to increase the fluid intake and decrease salt. You're correct. So the need for workup, I will point out, some people would argue about whether you need to work them up after a first stone. But remember that about half of stone formers will have another one within 10 years. This patient has multiple stones on imaging, so his risk of recurrence is probably higher. But if a patient was 65 and presents with their first stone, and doesn't have multiple stones in imaging, it might be very reasonable to say just drink a lot and dispense with the workup. Calcium oxalate accounts for most stones, followed by calcium phosphate. Other stone constituents are less common. Where possible, you should retrieve a stone and send it for analysis to find out what the stone is made of, so you can tailor therapy to preventing that. Be aware this patient doesn't need lithotripsy yet because most stones of this size, less than 8 millimeters, can pass spontaneously. In interpreting his 24-hour urine, supersaturation numbers would have been useful, but I didn't give those to you. But in general, his urine volume reveals a low volume, high calcium excretion, low citrate excretion, and a high sodium intake. So you've got a lot of choices about what to intervene on. But the cornerstone of therapy is always, this is a concentration and a saturation problem, so increase the volume of urine produced by increasing his intake to 2 liters a day or more. Be aware that a high sodium intake promotes calcium excretion, so a reasonable first step would be to reduce his salt intake and repeat the collection, see what calcium excretion is at that point. Salt and water intake. Decrease salt, increase water. Allopurinol can be effective both in calcium and uric acid stones, especially if you're uric. Thiazides decrease calcium excretion, prevent recurrence. Great first-line choice if someone has hypertension, and you could give him K-citrate, but not sodium citrate to prevent his stones. Lastly, avoid a low calcium diet because that promotes osteopenia. If you're hypercalciuric, you want to probably think about a thiazide rather than reducing dietary calcium. 82-year-old man goes to the intensive care unit following an XLAP. I'm going to read through this question quickly. He's getting better for the initial few days, but on the 5th day becomes lethargic, hypotensive, and oliguric with intermittent arrhythmias and some ectopy. His abdominal exam shows marked tenderness, but labs show an amylase of 225. Creatinine's a little bit elevated and bicarb down with a slight gap and a slightly elevated CK. What's the explanation? Propofol toxicity, propylene glycol, ATN, or dehiscence at the suture line with intra-abdominal sepsis. All right, in the interest of time, I'm going to go on here. All right, so you guys are pretty divided here. Actually, the correct answer is propofol toxicity. Propylene glycol is a carrying agent for some drugs seen with, particularly with lorazepam, digoxin, or phenytoin infusions, most often with lorazepam for DTs because they get high doses. It's the carrier, not an active drug, but it is osmotically active, renally cleared, and metabolized to lactate. And so you can get an osmolar gap and an anion gap and osmotic diuresis leading to renal failure, and you can dialyze it if necessary. But that's not what's going on with this patient. The fact that he has an elevated amylase might suggest pancreatitis, but that wouldn't explain a lot of his other symptoms. And a surgical catastrophe seems less likely given the location of his symptoms and the CK leak. What he has is propofol infusion syndrome, which is characterized by confusion, cardiac toxicity, pancreatitis, and rhabdo. You can also get lactic acidosis and kidney injury. The risk factors are rapid infusion or prolonged infusion, and generally you treat with supportive care and withdrawal of propofol. I think I have just 2 more questions, so just maybe by a show of hands, should I go on for another minute or 2? Okay, well, I heard a smattering of yeses, so I'll go on. We don't have much longer. 77-year-old dialysis patient, progressive discomfort, arms and legs. This picture is what you see, and we're talking about these areas here and perhaps here. Here's some more imaging down here and here. So it looks like let me just start that. Okay. So what's the diagnosis? Scleroderma, calciphylaxis, beta microglobulin amyloidosis, or nephrogenic fibrosing dermopathy? Okay. All right. Oh, so we've got a lot of different answers. Most of you actually thought this was calciphylaxis, but it's actually NFD. That's characterized by diffuse hyperpigmented or yellow brawny induration of the skin over forearms and shins. It can be diffuse and progressive and lead to disabling flexion contractures. They appear similar to plaque scleroderma, but the distribution is different, and it's not associated with the antibodies like the SCLC70 antibodies that you see in scleroderma. You can diagnose it clinically, but if you biopsy it, you would see CD34 expressing dermal spindle cell proliferation without inflammation. It's strongly associated with prior gadolinium exposure, especially in dialysis patients, so we don't see much of this anymore because there's some major restrictions on gadolinium use. You might see it, however, in a CKD patient who got a contrast, MRI contrast, without realizing the severity of their CKD. There have been some suggestions to do post-dialysis, post-exposure dialysis, but it's not really clear what the exposure level you need to induce this disease is or how much you need to remove. So if someone's already on dialysis, it might be worth doing. I don't know that I would start a patient on dialysis for that purpose. Next question, 32-year-old pregnant woman, first pregnancy, past medical history of bipolar disease on carbamazepine. She's admitted 11 weeks with nausea, vomiting, and labs of a creatinine of 0.5, a sodium of 133, and a K4. Blood pressure is low normal for pregnancy at 100/60, and her exam is pretty unremarkable. We're asked to see her for hyponatremia. So what would you do here? Start normal saline to replete her volume, fluid restrictor to 1.5 liters a day, get urine electrolytes, hypertonic saline, or nothing. Okay. All right, most of you don't think any therapy is necessary. That's correct. This is a normal sodium level for pregnancy. You don't need to do anything. Sodium level decreases by about 5 milliequivalents per liter during pregnancy due to changes in threshold for ADH release and production of placental vasopressinases, as well as changes in thirst threshold. Notably, that hypertonic saline is really not indicated except in severe and probably symptomatic hyponatremia. Moving on, she's discharged, continues pregnancy uneventfully to 38 weeks when she's admitted with vaginal bleeding. She now complains of frequent urination and thirst, as sodium is 138 and urine volume is 5 liters per day. Choose the best answer. She has lithium-induced diabetes insipidus. Serum glucose should be checked to rule out pregnancy-induced diabetes mellitus. DDAVP is better than AVP to treat this, or you should do a water restriction test. All right, a lot of different answers. So the answer is C. The rise of serum sodium at this stage of pregnancy is strongly suggestive of a pregnancy-induced DI. Placental vasopressinase, as I mentioned earlier, increases during pregnancy and is increased rather significantly by the beginning of the 3rd trimester, end of the 2nd trimester. And if you have pre-existing diabetes insipidus, it can be dramatically exacerbated by this. In a minority of patients, this may cause de novo DI, and that typically has an onset when placenta reaches its maximum size and produces the most vasopressinase during the really during the 3rd trimester. Because it inactivates vasopressinase, but not its structural analog, the synthetic version DDAVP, a failure to increase urine osmolality with AVP while responding to DVAVP can be used to diagnose it if you wanted to take all those steps. This will typically resolve with removal of the placenta. And I think this may be the last question, or we should probably stop anyway if it's not. 76-year-old PD patient has profound hypoglycemia. He takes 10 units of long-acting insulin twice a day and short-acting insulin in between meals. His wife states that he's been in his usual state of health. The exam's unremarkable, no white count, normal imaging, and cultures. Why is he hypoglycemic? A malfunctioning glucometer, a cold infection, icodextran, or reduced insulin clearance? Okay, so most of you actually chose the wrong answer here. So the answer is it's the icodextran. So icodextran is a glucose polymer. It's metabolized to maltose, maltotriose, and maltotetraose. And what you need to realize is that glucometers measure glucose based on oxidative reactions. I'm not going to read you the rest of that sentence. It's too hard to pronounce some of those words. But maltose and the other metabolites of icodextran can interact with these enzymatic processes and cause the glucometer to believe that there's hyperglycemia when there isn't, and then patients respond to that with an insulin overdose. Okay, I think we're about 7-8 minutes over. This may be the last question, but I think we should probably stop here because we're kind of over at this point. So if you want to read through it, I'm happy to answer the questions on the side.
What's the answer?
What's the answer? So the answer here is D. All right, at this point, I'll go through this last slide. So the patient has juvenile hyperuricemic nephropathy that's caused by defects in the UMOD gene, which encodes for TAM-Horsfall protein. That tends to be associated with hyperuricemia, gout, and slowly progressive bland renal failure. It's not necessarily juvenile. I should also point out that defects in this gene have been associated on a population basis with an increased risk of CKD. Whether that's the same phenomenon or something else is not clear in these large genetic studies. You may see small kidneys in ultrasound or medullary cysts, particularly if you do an MRI or a biopsy. And it's generally without a lot of proteinuria. If you do a renal biopsy, it's fairly nonspecific. You may see medullary cysts or interstitial nephritis or altered distribution of TAM-Horsfall protein if you alert the pathologist to actually stain for that. There are non-hyperuricemic forms as well, encoded by different genes. You don't necessarily have to have gout, so renin gene defects are a cause of hereditary interstitial nephritis, as are defects in the MUC1 gene. All right, I'm going to stop there. The answer is to 19. All right, so the answer is 20 ml per kg per hour. Okay, I think they give you the answers later.